Thank you and good morning to everybody. Uh, I'm basically going to be talking about dyspnea, breathing difficulty, and since it's with or without a history of smoking and atopy, the focus is going to be predominantly on asthma and COPD. So, what do we understand by dyspnea or breathlessness? It is derived from the Greek word which is hard breathing, which is often described as shortness of breath. Now, important thing to remember is dyspnea is a subjective sensation. A person will say that he is feeling dyspneic. There's experience of breathing discomfort that consists of a qualitative, distinct sensation that vary in intensity. So you could have a feeling of dyspnea when you are even doing mild activity, but an athlete who runs 100 meters may not complain of dyspnea because he doesn't feel that that sensation is abnormal for the degree of activity that he or she has done. So it's a subjective sensation which an individual feels that is causing shortness of breath or breathing difficulty, and it has nothing to do with the degree of activity a person is doing. You could have dyspnea on minimal activity, and a person may have no dyspnea even if he runs 500 meters. So it's a sensation patients report which, if you talk to individuals, they may say they have a tightness of the chest, they're not able to breathe, air hunger. All of this actually is what dyspnea is all about. Now, if you look at causes of dyspnea, predominantly it's cardiovascular or respiratory causes. But it's important to remember when we have a person who comes to us with a history of dyspnea, we should look beyond the cardiopulmonary system. You can have dyspnea because of metabolic disorders, it could be because of neuromuscular disorders, psychogenic conditions. A young lady who comes to the emergency with a panic attack may complain of dyspnea, and she could get wrongly diagnosed as having asthma with a silent chest and get steroids and nebulization. So it's important for us to understand that dyspnea can have many causes which could be beyond the cardiopulmonary system. The mechanism of dyspnea is something that it's still not clear, but it's perceived that there's imbalance between pulmonary ventilation and the work of breathing or the drive to breathe, and when that happens, the brain senses this as something abnormal, and that is what is dyspnea. So dissociation between pulmonary ventilation and the respiratory drive, which arises from a mismatch between the afferent receptors which are present in the airways, the lungs, the chest wall, the vasculature, and the central motor activity. So you have the afferent signals and the central motor activity, and when this imbalance occurs, you start having a sensation of dyspnea. So you have traditionally uh, you have traditionally uh, the afferent signals which come through the lungs, the bronchi, the vasculature, which go to the brain and the brain stem, and also you have the afferent signal which give a command to the respiratory muscles as far as breathing is concerned. So if the effort of breathing is more than what is perceived as by the afferent signals in terms of the output, it leads to an abnormal sensation, and that leads to the sense of dyspnea. So if you look at major mechanism of dyspnea, it could be basically primary amyloid activity, which is more centrally mediated, could be because of anxiety, depression, post-traumatic stress disorders, panic disorders, all will lead to feeling of dyspnea, which has nothing to do with the cardiopulmonary system. Then it could be because of respiratory system, a neuromechanical dissociation. Like I said, that the work of breathing is basically much more, the neuromuscular breathing effort is much more than the anticipated airflow or the chest exertion, and this is then perceived as a sense of dyspnea. So breathing effort is more than the return effort, and this leads to sensation of dyspnea. This could be because of increased airway resistance, as we see in asthma or COPD. It could be because of decreased lung compliance, as one would see in ILD or in individuals with obesity, and increased dead space could be because of alveolar hypoventilation or causes of centrally mediated causes itself. And this would lead to ventilatory stimulation. It can also occur because of increased cardiovascular pressure. Pulmonary vasculature, the J receptors, also known as the unmyelinated C fiber receptors, present. J means justa capillary, so they are present just around the capillaries in the lungs. And whenever there is a little bit of left ventricular failure, this causes these receptors to get stimulated, and they cause the sensation of dyspnea. The J receptors were actually described by an Indian, Dr. Paintal, who was also the director of Patel Chest Institute. He described the J receptors way back in the 60s, and they were subsequently also known as C5 or unmyelinated receptors. Then you have the intracardiac baroreceptors, the aortic baroreceptors, and then important to remember that acidosis, which could be because of lactic acidosis, diabetic ketoacidosis, renal failure, all can also lead to sensation of dyspnea. So when you have an individual who comes to the emergency with breathlessness, just don't focus on the heart or the lungs. Keep in mind that breathlessness can have multiple causes, and that's what you need to really look at. So the causes of dyspnea, like I said, could be respiratory, could be cardiovascular, could be neuromuscular, could be systemic, could be psychogenic, and could be upper airway obstruction. So we have a large number of conditions which cause breathlessness in an individual who comes, and they could be from airway related lesions, parenchymal lesions, vascular region, could be related to the cardiac system, and like I said, if you have neuromuscular weakness, that itself can cause it. And then one of the commonest cause of dyspnea, chronic dyspnea in our country, is actually anemia. Women who have low hemoglobin tend to complain of dyspnea, which could be just related to anemia itself. And thyrotoxicosis, because of increased basal metabolic rate, is another cause of dyspnea which gets missed. And there are individuals who come that they're suddenly having dyspnea. You feel their pulse, they have significant tachycardia, but everything else is normal. Don't forget to get a thyroid function test. This could just be an underlying thyrotoxicosis. And then you have psychogenic causes like I mentioned, and upper airway obstruction. So I'll focus on how will you approach a patient who comes to you with breathlessness. So first of all, you would obviously look at the course or the onset of disease. Acute dyspnea, subacute, which lasts over days or weeks, and chronic, which is recurrent or for months or years. So if you have a person who comes with, let's say, a pneumothorax, pulmonary embolism, or acute coronary syndrome, that could be something which is acute. Subacute could be a person who is having, let's say, pneumonia, or you could have even an ongoing rapidly progressive interstitial lung disease, or a gradually increasing pleural effusion. That could cause dyspnea which occurs over days to weeks. And chronic could be a person who has something like COPD, where the progression is over a period of time, or interstitial lung disease which progresses gradually over a period of time. Some patients who have cardiomyopathy also may have chronic dyspnea which progresses over a period of time. So when you have such a varied number of causes, the next thing would be to look for associated symptoms. Is there associated wheeze? Can I feel a stridor? Is there history of cough with expectoration? History of fever, weight loss, anorexia, hemoptysis will tell you that these are likely to be a pulmonary cause for dyspnea. Is there chest pain, pedal edema? Is there history of paroxysmal nocturnal dyspnea? More likely to be a cardiac cause. And then is there anxiety, confusion? Then you're looking more at central causes. So the history sometimes becomes very important for you to start trying to localize what could be the cause of dyspnea. And then when you examine these patients, you must look for tachycardia, tachypnea, fever. Is there accelerated hypertension? Is the patient in respiratory distress? Is he using the accessory muscles of respiration, which would suggest severe involvement? Is there pursed lip breathing? Pursed lip breathing would suggest obstructive airway disease. A lot of people who have some degree of intrinsic PEEP tend to breathe through pursed lips so as to be able to counteract that PEEP that they have. Prolonged expiration, and then wheeze, the quality of breath sounds, and then you need to look for crepitations in the chest or bronchi, and cardiac examination looking for the S3, S4, looking for the elevated JVP and other features of pulmonary hypertension if you have a loud P2, and then whether there is evidence of ascites or pedal edema. The first investigation that most individuals would do would be a chest X-ray looking for an effusion, pneumothorax, consolidation, whether there is an hyperinflated chest with low placed diaphragm, a tubular heart which would suggest emphysema or air trapping for cardiomegaly. You do an ultrasound now, which is something that is become standard of care, looking for the A lines, B lines, for lung slide to look for pneumothorax, pleural effusion. And in an acute situation, sometimes it may be worthwhile to also do a brief scanning of the legs to see whether there is deep vein thrombosis, which may give you an idea that you may be dealing with a vascular event like a pulmonary embolism. A D-dimer, arterial blood gases, ECG, cardiac markers are all something that one would do depending on what your index of suspicion is, a hemogram, and then of course if required a CT scan, and depending on whether you're suspecting pulmonary embolism, you may also do a CT pulmonary angio, or depending on what you're thinking of. So let's take one case and look at it from the obstructive airway point of view. So this is a 67-year-old female. She is a smoker, a smoking index of 800, hypertensive, diabetic, and has a history of shortness of breath on exertion off and on for the last 10 years. So the breathlessness is there for the last 10 years. But now she's come to the emergency with acute onset shortness of breath, cough with expectoration. She is tachypnic, using accessory muscles of respiration. There is reduced breath sounds bilaterally. She has a hyper resonant note on percussion, and there's bilateral wheeze, and she has pitting pedal edema. Her blood pressure is alright, so diastolic is slightly on the higher side. She is having a high respiratory rate and pulse. Saturation is 88% on room air. Blood gases show that she has acidosis. The pH is 7.27. The PCO2 has gone up 76 with fall in PO2 of 62, and the bicarb is also high, suggesting that there is some degree of compensation as far as metabolic alkalosis is concerned. So this is an acute exacerbation of COPD. Now, what is an acute exacerbation of COPD? If you look at the current GOLD guidelines, the GOLD 2023 guidelines, an acute exacerbation of COPD is being redefined as an event characterized by increased dyspnea and or cough and sputum that worsens in less than 14 days. So they have now put in a timeline which was not there in the past, which may be accompanied by tachypnea and or tachycardia, and is often associated with increased local and systemic inflammation caused by infection, pollution, and other insult to the airways. So this is the definition of an acute exacerbation or a COPD patient coming with acute shortness of breath. What is the pathogenesis? Now, we all know that COPD is an inflammatory condition, and you already have inflamed airways as far as COPD is concerned. Any exposure which could be viral, and there is now more and more data suggesting that one of the common causes of acute exacerbation of COPD could be a viral infection rather than bacterial. So it could be viral, it could be bacterial, and it could be related to exposure to air pollution, one thing that we see in Delhi very often during the winter months. All of this leads to worsening of the underlying inflammation in the airways, which leads to multiple effects as far as the lung is concerned. Because of narrowing of the airways, there becomes more of alveolar hypoventilation, there is more of VQ mismatch, and this leads to hypoxemia. There is mucus hypersecretion, mucus plugging, and there is edema, and also there is bronchoconstriction, which leads to increased work of breathing. All of this leads to the symptoms of acute shortness of breath, rise in PCO2, fall in oxygen, and patient coming to the emergency. Now, this has a negative impact as far as an individual is concerned. It affects the patient's quality of life. It has an effect on symptoms and lung function that may occur over weeks and takes a long time to recover. Each exacerbation of COPD leads to a further decline in lung function and further worsening as far as the individual is concerned. It is associated with significant mortality. We all see that in the ICU, and especially patients who require hospitalization. So when we have one exacerbation of a person who comes with acute exacerbation of COPD, it leads to a faster decline in lung function. The rate of decline of lung function becomes faster. It leads to a poorer quality of life in these individuals, higher mortality, and greater airway inflammation. So what has been actually shown is that if you have an individual who has COPD, each exacerbation actually leads to further decline in his lung function, the quality of life, and this actually hastens the overall mortality and morbidity in these individuals. So it's an important thing to keep in mind that we should not only treat the exacerbation, but when we send these patients home, make efforts to prevent further exacerbation, which could be in the form of pulmonary rehabilitation, in the form of vaccination, and in the form of trying to correct whatever correctable causes we have, which could be related to the insult that the patient may be having. The physical signs of severe exacerbation are very simple: marked dyspnea, tachypnea, pursed lip breathing, use of accessory muscles at rest, reduction in the activity of daily living, acute confusion, and cyanosis and pedal edema. So what the GOLD Guidelines 2023 actually says is that you confirm the diagnosis, and remember, any patient who has underlying COPD, if he comes with acute exacerbation, you must also consider the other differential diagnosis which can actually be there. So heart failure, pneumonia, pulmonary embolism are also not uncommon in patients with COPD. These are patients who may be sick, less mobile, sitting all the time, have a higher chance of pulmonary embolism because of the fact that this occurs at an older age group. They are chronic smokers. They also have a high risk of having coronary artery disease and may have heart failure, which may be the cause of dyspnea rather than COPD. But if you have an acute exacerbation of COPD, then you need to really look at dyspnea scores, the visual analog scale, the respiratory rate and the heart rate. And if the respiratory rate is less than 24, heart rate is less than 95 beats per minute, this is likely to be a mild exacerbation. You can also look at the resting saturation. Normally it would be more than 92% while the patient is on room air. Or if there is a change of 3% from the baseline of what you know the patient is having. So if the patient is already having a saturation at rest of 92, then a fall in 3% would signify that there is an exacerbation. For moderate, you have a respiratory rate of more than 24, heart rate of more than 95, a resting saturation of less than 92, or a change of more than 3% as far as saturation is concerned. And what has been added is the CRP, that the CRP is more than 10. And if you have an ABG, it could show hypoxemia and hypercapnia, but they will not be acidosis. The pH would still be in the normal range, suggesting that this is still a moderate exacerbation. In a severe exacerbation, they would also be features of a fall in pH, suggesting severe acidosis. So such a patient comes in the emergency. When would you consider hospitalizing these patients? Severe symptoms, sudden worsening, high respiratory rate, decreased saturation, confusion and drowsiness are all indicated for admission or hospitalization. Acute respiratory failure, onset of new physical signs, and failure of exacerbation to respond to the initial medical treatment, which could be the nebulization that you give to these patients. If they are not responding, then obviously you would consider admission or presence of serious comorbidities. The other important thing to keep in mind is that sometimes the patient may not be that sick, but may have comorbidities or may not have that much of support at home, and one is worried that when he goes home he may not be able to look after himself, and this exacerbation may actually deteriorate and may not get picked up. In such a situation also, it's better to have a low threshold and admit the patient. So if you look at the GOLD guidelines, what it really says is that assess severity of symptoms, administer supplemental oxygen, which could be usually at a low flow, obtains blood gases, and then the mainstay of treatment is bronchodilators. When you're giving bronchodilators, by and large one would give the short-acting bronchodilators, a beta-2 agonist and an anticholinergic. You could give them separately or you could give them in a combination. Long-acting beta-2 agonists really are not given in an acute stage. You would tend to give them more when the patient is being discharged or as a follow-up. In an ideal situation, we would give it with a nebulizer, but if you are working in a situation where nebulization is not available, you can give the short-acting beta-2 agonist also using a spacer device. And if you can give multiple doses of the inhaler through the meter dose, inhaler and spacer, you may still achieve some degree of bronchodilation. One must consider giving oral steroids, and this has been something which has come over the last, I would say, 2 decades, that steroids do help even if it's an exacerbation which is infective in origin. And antibiotics to be considered when signs of bacterial infection are present. And what has changed dramatically over the last 15-20 years, the aggressive use of non-invasive ventilation, which has actually really changed how we are managing our acute exacerbation of COPD. I remember 15 years ago, almost all patients who came with acute exacerbation would probably get intubated, and very often they would recover within 48 to 72 hours. Some patients would even pull out the endotracheal tube. All that has changed, and I think now the number of patients that you're actually intubating has come down dramatically because of aggressive use of non-invasive ventilation. You must also monitor for fluid balance, consider DVT prophylaxis, and treat other conditions which may be present. So I'll just sort of quickly touch on the role of steroids, because this has been something that has come up in a big way. Initially, when this initial studies came, and there was an article in NEJM published, I think, way back in 1999, that article clearly showed that 2 weeks of steroids made a difference as far as readmission was concerned and overall mortality was concerned. So for a long time, one was giving steroids for 14 days in all patients with acute exacerbation of COPD. Then we had this reduced trial which looked at short-term versus conventional corticosteroids, therapy in acute exacerbation. Conventional, like I said, was 14 days. And this was done in Swiss teaching hospitals, looked at 5-day prednisolone, 40 milligram daily versus 14 days, which was then the standard of care. And the primary endpoint was time to next exacerbation, and the secondary outcome was FEV1 and death. And they followed up these patients for 6 months. What they found was that if you look at the intention to treat analysis, if you look at the per protocol analysis, death or exacerbation, there was no difference if you gave steroids only for 5 days rather than giving it for 14 days. The reason I'm stressing this is that very often one tends to continue steroids even for a longer time. But I think the other important message is that there was no need to taper the steroids as such. So oral treatment was as effective as IV treatment. If you give IV, you can restrict it to 24 to 48 hours and switch over to oral medication. 5 days was adequate. You didn't need to give it for longer. There was no need to taper. And interestingly, they found there was no evidence for concomitant addition of nebulized steroid during the exacerbation. So if you're giving oral steroids, adding nebulized steroids actually did not make much of a difference as far as this study was concerned. What about admissions to the ICU? So if you have severe dyspnea which is not responding adequately to initial emergency therapy, changes in mental status, persistent or worsening hypoxemia, a PaO2 of less than 40, or there is severe respiratory acidosis, a pH of less than 7.25, supplemental oxygen and non-invasive ventilation should be considered. Again, like I said, you must have a low threshold and then take the indication. If there is a need for mechanical ventilation, if the patient is hemodynamically unstable, the patient does need an ICU admission. When would you really think of non-invasive ventilation? So if there is respiratory acidosis, PCO2 starts going over 45 and you find your pH is falling to less than 7.35, you should start considering the patient putting the patient on NIV. If there is features of severe dyspnea like respiratory muscle fatigue, increased work of breathing, or both, use of accessory muscle or respiration, you find that there is paradoxical motion as far as the diaphragm is concerned, there is intercostal retraction, and persistent hypoxemia despite supplemental oxygen therapy, I would suggest that you consider non-invasive ventilation. How does NIV work? What does it do as far as patients with acute exacerbation of COPD is concerned? It is multifactorial. It decreases the work of breathing, it helps and decreases the load on the respiratory muscle, provides rest to the respiratory muscle, decreases respiratory muscle fatigue. It also counters the intrinsic PEEP which happens in patients with COPD because of the air trapping which happens, helps to reduce acidosis, and it also buys time for bronchodilators, steroids to start acting, and therefore is able to avoid intubation. So when would you consider giving NIV and what would be the ideal situation? So if your pH is more than 7.35, the patient is stable, you may or may not give NIV, it's usually not indicated. If your pH is between 7.3 and 7.35, you will need to give, NIV is advised. 80% of patients will get better with conventional treatment, but NIV will help, and this could be given in the ward also. But if you have a pH which falls below 7.3, so 7.3 to 7.2, NIV will definitely help, strongly advise, and this is a group that you must aggressively give NIV, could be given in the ICU and ward. But if your pH starts falling to less than 7.2, you need to do it in a very closed monitoring situation in an ICU, because in such a situation these patients may not tolerate, or the NIV may not work, and there is a chance that 50% of these patients may need to be intubated. So you need to be more closely monitoring such patients as far as the pH is concerned. This is an old study, very old, but I think still meta-analysis, a Cochrane review, but still really changed how we started practicing, and this clearly showed that non-invasive positive ventilation reduced in patients with acute exacerbation of COPD, decreased mortality significantly, decreased the chances of endotracheal intubation, and this showed that decreased intubation by 28%, in hospital mortality by 10%, and like I said, it was more pronounced in severe COPD exacerbation when your pH was less than 7.3, and that's what led to the criteria of when you should give NIV as far as COPD is concerned. So it's more suitable, more effective in moderate to severe COPD. I've already given you the pH range that you should see, but there is no real data as far as what is the lowest threshold, and there are people who have given NIV when the pH is also as low as 7.1 and been able to get away with that, in terms of not having to intubate this patient. So you should consider NIV if a patient doesn't have any contraindication for it, and if there is an improvement with 1 or 2 hours of the trial, you are moving towards an area where your NIV should succeed, and it's something that you should then try and do aggressively. But when do you consider mechanical ventilation? It's also important that you do this at a proper time. If you delay ventilation for a long time, you may have more respiratory muscle fatigue, more spasm, and the patient may actually have a higher morbidity. So that is also very important. So unable to tolerate NIV or NIV failure, post respiratory or cardiac arrest. If the patient is not conscious or drowsy, agitated, NIV will not work. You will have to consider intubation. Massive aspiration, persistent vomiting, inability to remove secretions, because that is another very important issue, hemodynamic instability, ventricular arrhythmias, all are indications that you should consider mechanical ventilation. Let's move on to another scenario. This is a 25-year-old girl. She is with atopy and asthma since childhood, on budesonide inhaler and salbutamol, history of hospitalization 10 months back and managed with IV steroids. She comes to the emergency room with fever and worsening and shortness of breath for 3 days. No preceding upper respiratory tract infection. She has a heart rate of 120, respiratory rate of 40, room air saturation is 92, and she has diffuse wheeze or rhonchi in the chest. Her pH is 7.36, PCO2 is 40, you could say that's normal, PaO2 is 64, and she has a bicarb of 28. Now the issue is this something of concern or not? I would say that the ABG is a little bit of a cause of concern, and I'll come to that. But if you now look at the GINA guidelines, the GINA guidelines defines asthma exacerbation as episodes characterized by progressive increase in symptoms of shortness of breath, cough, wheeze or chest tightness, and progressive decrease in lung function, and they represent a change from the patient's usual status that is sufficient to require a change in treatment. So any change from the usual status of the patient which requires a change of treatment with increasing symptoms of shortness of breath, cough or wheeze or chest tightness would classify as an exacerbation as far as asthma is concerned, and they occur in patients with pre-existing diagnosis of asthma, but they can occasionally be the first presentation of asthma. So you may have a patient who denies any history of asthma but comes to the emergency with acute onset shortness of breath, has extensive wheeze, and this may be the first episode as far as asthma is concerned. Now again, like COPD, each asthma is a chronic inflammatory state, and each exacerbation causes more and more inflammation, again which leads to airway remodeling, and this itself therefore leads to structural changes in the lungs. So again, it's important that we prevent exacerbation, because each exacerbation leads to the loss of the reversibility. Asthma, remember, is a reversible airway disease. But then you have patients who are not properly treated for asthma, for the chronic part and for the acute exacerbation. This leads to ongoing chronic inflammation, airway remodeling, structural changes, and the reversibility of this asthma gets lost, and they start behaving more and more like COPD rather than asthmatic individuals. Triggers for exacerbation could be viral infections, again one of the more common causes. More data as we accumulate even in our country suggests that since we were not doing tests for viral infections, we were missing them, but viral infections are a common cause of exacerbation both for COPD and asthma. Allergen exposure, food allergy, outdoor and indoor air pollution, and of course seasonal change. But very important is the poor adherence to inhaled corticosteroids. If you start taking a detailed history from your patients, you will find that compliance with inhaled corticosteroids is very poor in asthmatics in our country. And that's predominantly because there is a lot of stigma attached not only to the steroids but to the use of inhalers. And that is why a lot of patients don't use inhalers or tend to use it suboptimally or don't know how to use it. And all of this leads to an exacerbation of asthma. There is a lot of attention now that you should have a written asthma action plan. Patients should be given the responsibility of managing an exacerbation. If there is worsening of dyspnea, patient can be given a written action plan that you increase your reliever medication, increase your controller, review your response, monitor your peak expiratory flow rate, which is easy to do, and then you can even advise or give a short course of steroids so that they can start 40 to 50 milligram prednisolone for 5 days and see whether there is improvement, and then consult their doctors. Now, there is a lot of variation in our population. Many years ago, we tried to have a written asthma action plan to our patients. Many of the patients said that, they'd rather consult their doctor and decide what to do rather than take the responsibility of treating asthma themselves. So although the written asthma action plan is very popular in the West, in our scenario, there is still a reluctance by patients to do it on their own, and they would rather consult the doctors. But it is something that is useful, because at times when you have an acute exacerbation, the patient may not be able to approach the doctor or come to the emergency, and then having a written action plan, especially in those asthmatics who have brittle asthma, is sometimes useful. When you are assessing an acute exacerbation, you really need to look at the severity of respiratory distress. So you need to just see the ability of a patient to speak. Can the patient speak in complete one sentence without breaking his breath? Or is the patient repeatedly breaking his breath when he's talking to you? That means the patient is dyspneic, is breathless. Is there cyanosis? Is there use of accessory muscles of respiration? Is there sweating? Is there feeling of anxiety? All of this suggests that there is some degree of respiratory compromise. Look at cardiovascular stability, and you should look at the pulse oximeter. The higher the saturation, the lower the incidence of unwanted occurrence and less likely the presence of CO2 retention. Chest radiography will also help you, especially if you want to look at pneumothorax, pneumonia, especially in patients who are not responding over 6 to 12 hours. Another important thing that one should do is a regular arterial blood gases. It will help you to get an idea whether the patient is improving or not, and will also give you some idea of their electrolytes. But remember, in patients with asthma, they are hyperventilating. They're washing out the carbon dioxide. So in an asthmatic individual, a normal POC to an acute exacerbation is a sign of moderate to severe asthma, and something that the patient needs to be monitored for. So PaO2 of 60 millimeters of mercury and a normal or increased PaCO2 indicates respiratory failure. So just don't look at the blood gases and say this is an asthmatic PCO2 is 40 like the patient that I presented, and this is nothing to be done. A PCO2 of 40 in an acute exacerbation of asthma means that this is a sign of indicating respiratory failure. Patient is not able to wash out the carbon dioxide, and that can happen due to two things. One is respiratory muscle fatigue. Patient's muscle is getting fatigued and is not able to really wash out the carbon dioxide. Or this is a severe asthma with severe bronchoconstriction leading to air trapping, alveolar hypoventilation, and there is CO2 retention. Therefore, in a mild exacerbation, you will find the PCO2 is low, the pH is elevated, and the PO2 may be normal. But as you start having moderate to severe exacerbation, your PCO2 starts becoming normal and then starts rising. So in a moderate exacerbation also, the PCO2 is normal. So in an acute exacerbation of asthma, a normal PCO2 means that this is a moderately severe exacerbation of COPD, and you should not take it lightly. Asthmatic will wash out his carbon dioxide and should be on the lower side. When to intubate? Now that is another thing that nowadays very few asthmatics are getting intubated, and that is because of prompt medical treatment, aggressive nebulization. But if you have a person with respiratory arrest, cardiac arrest, or who goes into altered sensorium with severe asthma, there is a need to intubate the individual. Or despite optimal therapy, there is a decline in the GCS, the individual is agitated, drowsy. Like I said, there is a falling PO2, a rising PaCO2 with progressive acidosis. You may have to intubate these patients, but this is becoming less and less with aggressive treatment that we have now available. Way back in the late 1980s, the article was published in the American Journal by Tuxen and Lane, which actually introduced the whole concept of permissive hypercapnia. When I was doing residency, when in the ICU, we would always have an asthmatic who was hyperventilating. We would put the patient onto a similar tidal volume and respiratory rate because it was felt that the patient is breathing so rapidly. But then that article, which was in the Blue Journal by Tuxen and Lane, clearly showed that you were able to decrease the mortality by permissive hypercapnia. And you would have a patient who was breathing at a rate of almost 30 to 35 per minute. You would intubate this patient and then start putting the patient on a respiratory rate which was just 8 to 10 per minute, reduce the tidal volume to 6 to 8 ml per kg, but increase the IE ratio, allowed prolonged expiration, and decrease the air trapping or the hyperinflation that was happening at the expense of permissive hypercapnia. The PCO2 would rise. Remember, traditionally I said you don't want the PCO2 to rise. But in a patient on who has severe asthma, you start having an acceptable low pH and high PCO2 just so that you can decrease the hyperinflation and also be able to prevent barotrauma which occurs in these patients. Also monitor auto-PEEP and PEEP-LAT, and you could provide 80% of auto-PEEP if the patient is sedated or paralyzed. So the whole concept of permissive hypercapnia came in the late 80s because of actually the study which came in acute severe asthma, where you started giving your patients low tidal volume, low respiratory rate, and accepted a high PCO2. And there were times when you would even consider giving soda bicarb if there was severe acidosis, but you would continue to have a low pH and high PCO2. The GINA guidelines actually mention that you must first assess the airway, breathing and circulation, see whether the patient is drowsy, confused or has a silent chest. If that is present, if the patient is drowsy, confused or has a silent chest, straight away the patient should go to the ICU, you start aggressive treatment and even consider intubation. If that is not there, then you start triaging your patient depending on whether it's a mild or moderate asthma or a severe asthma, looking at whether the patient is talking in phrases or talking in words, he is basically agitated or not, what is using his accessory muscles, what is the pulse, what is the saturation, and what is the peak expiratory flow if you can do that. And then you consider the strategy of giving beta-2 agonist along with ipratropium bromide. So beta-2 agonist and anticholinergics, oxygen and oral corticosteroids is something that would consider. In severe asthma, you could even give intravenous MagSulf, magnesium sulfate, as a part of treatment strategy, and this is also as per the guidelines. There is a Cochrane review which shows benefit in acute severe asthma if you give magnesium sulfate, and then assess the patient and take a call on how you would treat this patient subsequently. So this is broadly giving an outline of management of acute severe COPD, a patient who comes with acute breathlessness as far as COPD is concerned or as far as asthma is concerned. What about dyspnea? So if you have a patient who comes to you with dyspnea, you would do an initial assessment and then see whether the patient is in respiratory distress or not. If the patient is in respiratory distress, then you will give supplemental oxygen, you will have an IV access, monitor the patient, see whether you can protect the airways and also assist ventilation. But if it is not there, then the first approach to a patient with acute dyspnea is to do a physical examination, look at the vital signs, look for the causes that I mentioned, and probably would do a chest x-ray. The chest x-ray would help you in a number of ways. If the patient is wheezing and has a clear chest x-ray, you could consider bronchospasm and anaphylaxis. If there are rhonchi present and there are infiltrates on the chest x-ray, consider pneumonia or pleural effusion. If the chest x-ray is clear and the patient has pleuritic chest pain, you could consider pulmonary embolism, acute coronary syndrome. And if there are interstitial patterns, your NT-proBNP is elevated, you could consider pulmonary edema or cardiac event. And if there is a pneumothorax, then you're looking at a cause of dyspnea as a pneumothorax or a hemothorax. So if you were to look at this, you would get a broad idea as to what could be the cause of acute dyspnea in a patient who comes to the emergency. So what I'd like to say that when you have dyspnea, it is a multifactorial symptom. So don't just look at the lungs or the heart. It involves a lot of physiological, psychological and environmental factors. You must be able to understand the differential diagnosis of dyspnea, and I've already tried to focus on airway disease like asthma and COPD, but remember dyspnea could be because of a cardiac cause, but it could be because of an extra pulmonary, extra cardiac cause, and keep that in mind. And a thorough and accurate assessment of the history, the clinical conditions, possibly a chest x-ray, would help you to decide what could be the cause of dyspnea as far as an individual who comes to the emergency is concerned. Thank you very much. Any questions? So the issue is the use of aminophylline in acute exacerbation of asthma. So I would say that current guidelines don't recommend aminophylline. I mean, there was a time when all of us have given a bolus of aminophylline and aminophylline drip along with steroids. Currently, we would use it only if you are finding that despite all other treatment strategies, patient is not improving, has severe spasm, and you're given magnesium sulfate, you may give an aminophylline drip, but it is not something that is in the guidelines. So the guidelines don't mention aminophylline at all because of the fact that it is a very small therapeutic window of only 10 to 20 milligrams per deciliter. So if you go beyond the therapeutic window, you will have issues of cardiac and neurological side effects. But one does give it in dire situations in the ICU, but it's rare.
Thank you, sir.